Well, a very good evening to one and all who's present in front of your screens. And on behalf of the Kidney Warrior Foundation, I take great pleasure to welcome each one of you who joined us for this live session. And a special welcome to our doctors this evening. It's the first time we are having an interaction with these two doctors. We have Dr. Rashmi SR, who's a nephrologist at the Manipal hospitals. We have Dr. Nitin Yashas, who is an oncologist at the Manipal hospitals. And what's special about today's discussion is this is probably the first time we're actually visiting this topic, as this has been a very recent discussion within the community itself. And today we are discussing how is CKD and cancer connected? Is there a connection? What is the connection? How do we detect them early? Preventive measures. And the interesting thing is we're going to see how CKD is in cancer and how cancer can be in CKD as well. With that brief introduction, you can keep your questions coming in live on Facebook. We'd love to answer these questions within our span of 1 hour. But in the meantime, may I request Dr. Rashmi, a nephrologist, to please take over. Thank you.
Thank you, Ms. Marian, for that kind introduction. So cancer and CKD. So can you see the presentation?
Yes, doc.
Yes. Okay. So cancer and kidney disease. So let me not put it as CKD, like cancer and kidney disease. How is it related? Which one comes first? So let me just have you run through a bit of an overview of the topic. So it is a complex interrelationship. So we have oncologist Dr. Nitin talk about how these two will coordinate, or whether the kidney gets affected first or the cancer comes first. What happens, we'll come to know about it. So chicken or the egg story again. So whether the kidney disease is a cause or is it a consequence? So we'll have to see whether again, we're coming back to the same point. And is kidney disease a low risk, medium risk, or high risk for cancer? So I would just start with the outline of the talk. What is the relationship between cancer and kidney disease? What are the risk factors for kidney disease and cancer, and vice versa? What are the types of malignancies which patients with kidney disease have higher risk for? What's the relationship between chemotherapy and kidney disease? What is the screening which is required to detect certain kinds of malignancies in patients with kidney disease, and prevention? If at all there's any prevention, can we do it? So chronic kidney disease and cancer. Cancer initially can cause a lot of changes in the kidney, which can be per se like in the kidney parenchyma or obstruction or due to the chemotherapy. And likewise, kidney disease itself can predispose to cancer. What are the risk factors for cancer with CKD? There are patients with chronic kidney disease. Many of the patients with chronic kidney disease have comorbidities like diabetes and hypertension. A lot of lifestyle factors, like my boss always used to say, the S's of lifestyle factors as the sedentary lifestyle, smoking, spirits, sugars, and stress, aging. And kidney disease is a chronic inflammatory and immunomodulatory state. Inflammation is a low-level defense mechanism which happens in the body whenever you get injured or whenever there's a fight or flight reaction. And it is also an immunomodulatory state. I mean to say that immunosuppression to some extent will happen in patients with kidney disease. Initially, the initial stages of kidney disease, it may not manifest much, but the later stages of kidney disease definitely yes. And the other reason why the kidney disease can predispose to cancer is accumulation of the carcinogenic compounds. Normally, the kidneys work to put out all the waste products out of the body, which doesn't happen whenever a cancer is developing. They develop certain compounds which are not put out. Oxidative stress and impairment of DNA repair happens in CKD. And there are a lot of viral infections which can happen in patients on dialysis, like hepatitis B, hepatitis C, which can definitely predispose to certain types of cancer, mainly liver cancer.
Dr. Rashmi?
The effects of immunosuppression in patients with, yes?
Yeah, your slides are not moving. So
no, I'm still in the same slide.
Okay, the same slide
Yes.
is cancer and CKD only, right? We are on the first slide yet.
Correct. Yes.
Okay, thank you.
So viral infections on dialysis and effects of immunosuppression by the CKD state per se, or even in patients with transplant. Next would be, what are the risk factors for kidney injury with cancer? So now we are going the other way around, how cancer causes kidney injury. There can be pre-existing risk factors like what we discussed, multiple comorbid conditions and aging as well. Cancer in the kidney, if a cancer happens in the kidney, then we may have to remove a part of the kidney or total removal of the kidney, which amounts to less amount of kidney functions for that particular patient. Cancer in the tract, or an outside cancer which can cause obstruction to the flow of urine, or any other cancer like bone marrow cancer or liver, which can be infiltrating into the kidney. Dehydration of the patient, because most of the patients with cancer, they will not be able to eat properly or take adequate amount of fluids, so dehydration. Infection, because they are on chemotherapy and effect of cancer per se, the infection is a large probability, and infection in turn leading to kidney injury. And definitely a large part of the kidney injury in patients with cancer happens due to chemotherapeutic drugs. So what are the types of malignancy which patients with kidney disease can get? Cancers are most strongly associated with dialysis include Kaposi sarcoma and other tumors of the oral cavity. Definitely other solid organ malignancies like the kidney, bladder, stomach, liver, and lung. This is the case in most of the other normal population as well, which I will be coming to. In post-transplant patients, skin is the most frequent site of malignancy, but that doesn't exclude transplant patients from having malignancy in any other organs. In contrast to cancer risk in patients with dialysis and post-transplant, early stages of kidney disease does not have much evidence saying that there is increased risk of cancer in CKD. So there's a lot of studies which have shown an increased risk of malignancy in CKD patients compared with the non-CKD patients. So that's a confirmed fact. But depending on the stage of CKD, the risk goes on increasing. Definitely, like what I said, the dialysis patients will have a much higher. And cancer has independently been recognized. So patients with cancer, can they have chronic kidney disease? Yes. Acute kidney injury? Yes. So cancer has independently been recognized as a risk factor for development of chronic kidney disease, which can later go on to end-stage kidney disease and dialysis. So what next? Now, how is the management going to be? Definitely, it's a challenging scenario, both for the patients and clinicians, definitely a roller coaster ride for the patients. Evaluation, the evaluation of kidney disease in CKD or, in cancer in CKD or non-CKD patients doesn't very much, the standard protocols are there, and definitely organ-specific evaluation depending on the symptomatology of the patients. But yes, in patients with kidney disease, there are definitely some restrictions on imaging. Suppose a patient with malignancy needs a contrast CT. Then a patient with CKD cannot receive contrast. It's a well-known fact. So that kind of restrictions will be there. We'll have to work around it. And chemotherapy dose modifications. These are the challenges which can happen in a patient with both coexisting. So chemotherapy and kidney. What are the complications of chemotherapy? Definitely the patient can develop a kidney disease per se in the kidney parenchyma, infection, or a state where a lot of death of tumor cells happens, and it is called as tumor lysis syndrome and definitely affects the kidney. But majority of the times, we try to detect what could be the cause of kidney disease and revert it back to normal. If it's not reversible, then definitely patient will go on to develop chronic kidney disease. There is definite dose modification required in certain drugs, group of drugs which are used for chemotherapy. Definitely not all drugs. There are particular groups of drugs which are used for chemotherapy, which needs definite dose modification. Depending on the apparent kidney functions of the patients, the GFR, the glomerular filtration rate, we calculate the dose and then give it to the patients. So when we are not able to use particular set of drugs, then there's always a doubt whether there's adequate treatment of malignancy or are there any alternative drugs which don't affect the kidney which are available. So this will require a constant and close liaison between the nephrologist and oncologist and patient care. And who are all eligible for screening in malignancy to detect malignancy beforehand? So these are the recommendations for routinely screened cancers in the general population. Generally, breast, colorectal, and cervical cancer are the ones which are regularly screened in the general population. So there are other cancers like the prostate malignancy, the liver, lung, kidney, and the skin, which are not regularly monitored. So to come back again, breast, colorectal, and cervical cancer are the ones which are regularly screened. The cancers that are not routinely screened are prostate, liver, lung, kidney, and the skin. So unless the patient has specific organ-specific symptomatology, we don't screen them in the general population. So coming to cancer kidney screening in end-stage kidney disease, either the CKD5 or on dialysis, whether it is worthwhile and cost-effective to screen patients in kidney disease. This was a recent article which was published in Acute Advances in Chronic Kidney Disease, which showed that screening is not recommended in all end-stage kidney disease patients, and it is not cost-effective. This is one thing which we get asked very frequently, whether we should go on screening the patients annually or biannually to screen for any particular kind of cancer, but definitely not cost-effective. Recommendations for cancer screening in kidney transplant recipients. So as you can see, in transplant recipients, there's no cancer which is not possible. Theoretically, almost all the cancers are possible, so definitely screening is required. Pre and post-transplant, we do screen the patients. Pre-transplant, we definitely, before putting in the kidney, if the patient has already had a malignancy, then we wait for at least 2 years post-remission, depending on the type of malignancy. Or if the patient has not had any malignancy or are definitely at higher risk to receive the immunosuppression post-transplant, a pre-transplant oncology screening will be done and then only taken up for transplant. And as you can see, the cancer screening protocol for post-transplant patients. So prevention, is there any way by which we can prevent the malignancy from happening? There are multiple things which were asked, with the early screening of... Hello?
I think someone's audio
Is
is
there...
on.
Can I continue?
Yes.
Yes,
Okay.
Doc.
So is there any early screening of CKD or general precautions for CKD which prevents cancer? Not much of literature or evidence is available about this. Definitely for the chronic kidney disease per se, you have to follow all the general precautions as recommended, avoid any kind of painkillers, alternative drugs, good control of BP, diabetes and all that. But does that prevent you from developing malignancy? Not likely. Dietary precautions, definitely depending on the stage of kidney disease, we advise the dietary precautions accordingly. Whether there's any role of probiotics, because there's a lot of discussion about the gut microbiome causing malignancy. Of late, there have been a lot of papers which are published on this. So there was a question raised about whether probiotics can alter the milieu and definitely prevent development of malignancy. Till date, not much of literature has been there on this, but no harm in taking probiotics. Role of antioxidants, it's the same again. Alternative systems of medicine, definitely we would not be the right people to comment on alternative systems of medicine, Ayurvedic, homeopathic medicine. But what we have observed very often is patients who do take these systems of medications with kidney disease, not 10 patients who are not, people who are normal. With kidney disease, we have seen a fairly rapid progression, though we don't have hardcore evidence for this. Better lifestyle measures, definitely avoiding smoking, alcohol, not avoiding a sedentary lifestyle, definitely goes a long way. Even if the patient doesn't have CKD, these are the measures which predispose anyone in the general population for malignancy, so better to correct those. Role of vaccination, we spoke about viral infections on dialysis like hepatitis B, which can definitely be prevented by vaccination. Definitely, that's why patients who are having CKD will be advised vaccination beforehand. Dietary and medication compliance, definitely a huge role in making sure the patient doesn't progress, at least from the point of view of CKD. Thank you for your patient hearing. I would love to hear Dr. Nitin's perspective on the oncology part of this, and we would like to take questions later.
Thank you very much, Dr. Rashmi. We can now stop sharing your screen. May I now request Dr. Nitin to kindly take over, who will be talking from the oncology side.
Yeah, thank you so much for having me here. I do see on social media the wonderful work that Kidney Warriors Foundation does. I would like to express my gratitude to Dr. Sundar for establishing this contact and giving this, and to Dr. Vasundhara and Marianne for giving this opportunity. So my talk, Dr. Rashmi has covered most of the oncology aspect also. So I will just quickly go through some concepts which is important for the public to understand as to essentially what is cancer and why does cancer occur and what can be done really to detect it early and also prevent it as such. So if we sort of look at it, when it's very important that every individual is aware about cancer, because we all know that knowledge is power, and it becomes the most important weapon against the battle against cancer. So I'll just go through quickly as to what is cancer, some of the facts and myths associated with cancer, what are the signs and symptoms of cancer, the lifestyle changes, and how can really we can reduce the risk of development of cancer, and the screening protocol. Now, generally, over the last 2-3 years, the entire world is obsessed with the letter C because of COVID. Now, there is a bigger C which has been plaguing the field of medicine for many, many years now, and that is cancer, apart from the other C, which is, of course, the increasing incidence of chronic disease. So when we talk of the word cancer, we sometimes tend to associate it as a terrifying illness, a terminal disease, and really no cure for it. But things have changed dramatically over the last 2-3 decades, and it's very important to have knowledge to break the stigma surrounding cancer as such. So very briefly, to sort of understand what is cancer, if we have normal cells in our body, they undergo a process where they are born, they divide, and when the time they differentiate into different types of cells, and when the time comes, they undergo apoptosis, which is nothing but cellular death. But how are cancer cells different? Because normal body cells grow, divide, and die in an orderly fashion. Now, cancer cells become immortal, and that is the basic physiology or pathology of cancer. Now, if we look at our body, and for the common public which is seeing, we all have DNA, which is like the software in our body. Now, any error in the software code in our body is termed as a mutation. Now, usually there's a robust repair mechanism that can eliminate these mutations. In fact, at this point of time, as I'm speaking, all of us might be experiencing mutations in our body because of the air we breathe, the water we drink, the food we eat, or due to many other causes. But there is a repair mechanism in our body that is able to eliminate these cells which are having this mutation. Now, it is when the repair mechanism fails and the mutations accumulate, that is when the repair mechanisms get overwhelmed and there is abnormal cell growth and division occurs, which become cancerous as such. Now, let's understand one thing. All cancers are driven by genetic mutations, but having genetic mutations does not imply it is hereditary. Like I said, mutations can occur due to a number of extrinsic or intrinsic factors. It's only when these mutations are passed on from one generation to another, we call it hereditary as such. And let's remember, and that's something I'll be coming to in a while, it's only 15% of cancers which are hereditary, and the rest are caused by a variety of factors, and a large part of it still remains unknown as to why cancers occur. Now, as I said, cancer cells are different because they do not die. They just continue to grow and divide in a disorderly fashion. Now, people often think of the word cancer as describing a single disease with a single cause. In fact, there are over 200 different cancers that can occur anywhere in the body. And in fact, in the same organ itself, we have different types of cancer. For example, in breast cancer, we start talking about, are they hormone receptor positive breast cancer? Or do they express a special targetable protein called HER2? Even when you look at kidney cancer, for example, you say that there are different kinds of kidney cancers. So really, we need to understand that we cannot ever talk of cancer as one disease, but rather it's very different with a lot of biological variability in how aggressive the cancer is, how fast does it grow, where does it spread to, and all that. So if you just look at this one diagram, it explains the beauty of our body and at the same time how complex our body system is. Those of you who are software engineers might be all familiar with networks and servers and those things. But this is just the number of circuits or networking which is required in one cell to keep our body functioning. Now, for example, if there is a mutation in one of these pathways, in one of these networks or servers, then it can lead to cancer as such. So the first myth that, and I'm glad that we are having this, is that there is no need to be aware of cancer. Now, cancer is the second most common non-communicable disease globally after cardiovascular disease. And we know that the incidence is increasing. Just to look at these numbers, and these are numbers which I just want you to pause and take a moment to look at. And this is data from 2020 Globocon. You almost have 13 lakh new cases of cancer in a year in the country. Just imagine that number. You have 13 lakh new cases of cancer in the country, and the deaths due to cancer occurring in about 8 lakh patients. So that's really the burden of problem. So again, when we talk, or rather there's a perception that if we see that there's an increase in incidence of cancer in a particular community, that may also be because there is an increase in the overall there's an increase in the overall incidence of cancer as such. And as we know, the most common cancers in females are breast, cervix, ovary, and in males, it's the lip and oral cavity, followed by lung and stomach as such. Now, why is there a need to know is that many people think, oh, we are young, or we don't have a family history of cancer, I can't develop cancer. The fact is anyone can develop cancer at any age, and we are seeing that there is an age shift where we are detecting a higher proportion of cancer in the younger population. But what is more worrying is less than 1/3 of cancers are detected at an early stage of localized disease in India. Most of the cancers in India we detected when it is already in late stage 2 or stage 3 disease. And in fact, in cancers such as lung, most often they present in a stage 4 disease. Why does this happen? Now, this happens again because of ignorance, because many people would ignore the initial warning signs and symptoms where cancer can be picked up at an early stage because they believe that cancers are painful. But let's understand that actually most cancers start off painless. It's only in advanced stages when they start infiltrating the nerves and blood vessels do they become painful as such. So what are some of the non-specific symptoms that point towards suspicion that yes, there could be cancer? When we say that there is reduced appetite for weeks, a persisting low backache, or an unintentional weight loss. Now again, some of these symptoms may be present in chronic kidney disease patients, and it's very important to understand whether these symptoms are present despite adequate dialysis or despite adequate control of the renal functions as such. So if we sometimes look at what are the warning signs, if you have a persisting shortness of breath, a change in bowel or bladder habits, postmenopausal bleeding, that women start noticing spotting after menopause has occurred, or sometimes a skin mole that changes shape, size, or bleeds, new lumps or swellings, particularly in the neck, axilla, or groin area. Now, these are things which point that, again, I would like to tell you that it does not mean it is cancer, but it only says that you need to get it evaluated and should not ignore it. And the biggest myth that comes is that cancer is not curable once detected. Most cancers are curable if detected in an early stage. Now, this is slightly older data, but if we look at it, most stage 1 cancers have a survival rate of 5 years exceeding 90%, even touching 100%. But as you can see, it dramatically drops when it becomes stage 4. And that is the importance of early detection, screening protocols, and even looking at prevention. So if we sort of look at what are the causes of cancer, we see that about 1/3 is caused by tobacco use, but the rest is more or less lifestyle related. And these lifestyle related causes are also predisposing factors to diabetes, hypertension, which directly or indirectly are also contributing to chronic kidney disease as such. So you can see that 20% of cancers are related to individuals being obese or overweight. 16% are due to cancer-causing pathogens such as certain viral infections. Again, a very important point when we start talking about transplant patients. 5% of cancers are again related to decreased physical activity or poor dietary habits as such. So this is one slide that I would like you to sort of pay attention to, because this sort of explains why anything can predispose to increased risk of cancer. Now we need to understand that anything in the body which causes increased inflammation or puts the body into overdrive with the inflammatory pathway is a risk factor for development of tumors. So anything that we talk of, if it causes increased inflammation, it causes reduced immunity, and at the same time, it can cause an increased incidence of cancer. I'm not going to talk much about smoking and alcohol as such causing cancer, because that is something that people are aware about. But as and more is what I would like to focus on is whether it's the normal population who do not have any diseases or patients who have underlying comorbidities such as diabetes, hypertension, or chronic kidney disease. Obesity is one of the factors which drives inflammation in the body as such. There are 13 cancers which are associated with being overweight or being obese as such. And on the contrary, being physically active lowers the cancer risk. Now, again, to the general population, the recommended physical activity is at least 150 to 300 minutes a week of moderate intense activity, or at least 75 minutes of vigorous activity. And as you can see, it has a lot more health benefits rather than just lowering of the risk of cancer, apart from lowering the risk of cardiovascular disease, hypertension, and diabetes as such. Stress is something that we should not ignore. Stress, again, is something which drives inflammation and reduces immunity. It was seen in a very simple controlled experiment which was done, where they looked at people who slept well and people who did not, and they saw that people who slept less had increased infection rate, and again, people who slept more also had better antibody production after vaccines. And this is again because sleep modulates what are known as natural killer cells in the body, which play a big role in immunity as such. In fact, the World Health Organization has labeled nighttime shift work as being probably carcinogenic as such. So in short, when we sort of look at lifestyle changes as such, it is very important to have a good, colorful, healthy diet, important to indulge in physical activity, have relaxation techniques and good sleep, because all these play a role in reducing the risk of cancer irrespective of the population. So Dr. Rashmi has covered most of it. This is just a summary that CKD and cancer are related. You have toxins which can cause chronic kidney disease. At the same time, you have toxins which can predispose to formation of cancer. Some of the therapies of cancer that we use, such as chemotherapy, radiation, can itself cause injury to the kidney. And of course, dialysis and transplantation is itself a risk factor for cancer as such. Now, again, like I told you, the one important slide is that of inflammation. Now, kidney dysfunction creates an inflammatory system in the body, which causes the ideal environment for cancer development. Now, again, the most common cancer that we see in men with end-stage renal disease are liver cancer, bladder cancer, and kidney cancer. And in women, it's bladder, kidney, and breast cancer. Now, the other thing that we need to understand is that there is remarkable improvement in the field of nephrology, to remarkable advances which have been happening. And patients with chronic kidney disease and even on dialysis have prolonged life expectancy. Now, this itself is one of the reasons why cancer is becoming much more prevalent in patients with end-stage renal disease. Also, apart from chronic kidney disease, patients on dialysis might have a more increased risk of cancer, and there's a higher incidence of bladder and urinary tract cancer. Some research has also shown that liver cancer and thyroid cancer can be seen in patients on peritoneal dialysis. So we all know, again, like I talked about the interplay between inflammation and immunity. So in transplant patients, because of the use of immunosuppression, the body's immunity is lower. Usually, like I said, the body's repair mechanism or the immune system can eliminate cancer cell. Particularly, most commonly we see Kaposi sarcoma or skin cancer, which represents 75% of the cancer cases in patients with transplant, though certain other types of solid tumors are also encountered. Now again, not only the inflammatory pathway, immunosuppression predisposes to oncogenic viruses or organisms which can predispose to cancer, which explains the increased risk of cancer in transplant patients. So when we talk of treatment, I'm touching upon it very briefly with some case stories. The latest advances, because some of you asked about this, is immunotherapy. Now, these are checkpoints which have revolutionized the management of cancers. Now, these are medicine which unblocks the body's immune system to fight cancer. So you can see this was a 63-year-old female who had a left kidney cancer with multiple lung, lymph node, and bone secondaries. And you can see between the two slides that after 2 to 3 months of treatment, the disease has completely gone. Again, a 44-year-old gentleman with a kidney cancer which had spread to the lung. And after immunotherapy, we can see certain times remarkable responses where the disease does disappear, which we encounter in about 10 to 15% of patients where they go into complete response as such. Of course, what has revolutionized the field of oncology is targeted therapy, where we analyze the genomic sequence of the tumor and identify, is there any particular genetic mutation that this patient's tumor is carrying to which a targeted therapy can be given. This was a patient of lung cancer with spread to the brain. Previously, we would have said survival is only 5 to 6 months. We identified that he had an ALK mutation, which is a genetic mutation, and we started him on an oral tablet, and 3 months later, the entire tumor has disappeared. Now, again, this not to sort of hype it up, but these are sort of mutations which are present in only 2 to 5% of the population. And when they are present, we definitely can be able to target and achieve brilliant responses as such. So what is screening essentially? Now, screening means you are identifying a disease when in a person who looks apparently normal, who looks well, but you're doing a test which is able to detect the disease at an early stage. And why screening is important is that by detecting it early, you're able to have the best survival and at the same time reduced expenditure. Because in oncology, cost of treatments is also something very, very important to consider. And as we can see in this beautifully illustrated graph, as and when we detect the disease at a higher stage, the survival chances come down, but at the same time, costs go up as such. So Angelina Jolie was someone who sort of really revolutionized and brought into forth the impact of genetic testing and risk reduction surgery as such. So we say for every woman, being a woman itself is a risk factor for breast cancer. So we say start mammography in the age group of 40 to 45 years, can be done yearly or switch to 2 yearly later. For those who are at high risk, particularly those who carry a BRCA mutation like that which Angelina Jolie had or have a very strong family history, we say you have to begin screening earlier at the age of 30 years and also combine it with the MRI breast. Cervical cancer was the most common cancer in our country. It is in second spot right now. We have HPV, which is the testing for the viral virus, which is responsible for causing cervical cancer in most cases, along with the pap smear done once in 5 years from 30 to 65 years. The most heartening thing is we now are in a position where we can have policy changes to eradicate cervical cancer because of the vaccine against cervical cancer, which we say should be given in the adolescent age group of 14 to 20 years as such. Some of you might have watched the Marvel movies. We sadly lost the person who played the role of Black Panther. Colon cancer screening is one very effective screening. We say age group 45 to 75 years, maybe even 50 years onwards. Just a colonoscopy done once in 10 years. That is enough. Once in 10 years is able to detect the cancer at an early stage. And remember, even before the disease becomes cancerous, if there are any abnormalities seen, it can be removed from in the same colonoscopy setting as such. So in short, to summarize about cancer as such, they are driven by genetic mutations. There are various things which drive these mutations, right from smoking, alcohol, lifestyle changes. Having chronic kidney disease because of the inflammatory state that the body is in is itself a risk factor for cancer, and those post kidney transplant have lowered immunity, which again predisposes them to cancer. we have a lot of treatment options for cancer, which again, most of them can be safely used in kidney cancer patients, as Dr. Rashmi mentioned, with dose adjustments, changing the type of drugs we use, scheduling it based on the dialysis days and all. And of course, we need to watch out for the side effects. And the most important thing is we always say prevention is better than cure. And in cancer, sometimes prevention may not be possible, but we say early detection definitely transfers into cure. So with that, I would like to end my talks, and we would be happy to have a discussion and take any questions.
Thank you. Thank you very much, Dr. Nitin, for that in detail presentation on such a heavy topic, yet broken down for a common man like me to understand with in-depth knowledge. Was not planning to start here, but since you spoke about immunotherapy, is it available in India and what's the cost like?
Yes, so immunotherapy is easily available in India. Access is not an issue. At Manipal, Dr. Ahmed, Dr. Poonam and all, I mean, under their guidance, we have been using immunotherapy for many years now, more than 200 patients. And we have seen remarkable results, particularly in renal cancer, lung cancer, and especially cancer which has deficiency in the repair mechanism. Now, these are particularly sensitive to immunotherapy. The barrier to immunotherapy does remain the cost as such. And based on the various support programs which companies offers, the cost of each dose may vary somewhere between 1 lakh to 2 lakh as such. Now, typically, again, depending on the type of drug used, the immunotherapy is given at every 2-weekly or 3-weekly schedule. We give it for about 4 to 6 doses and then do a reassessment scan to look at the response and then plan the further treatment as such.
Okay. One more question on immunotherapy. Does it work for transplant patients or is it too risky?
Yes, so that is the sort of, so if we look at the original trials in which immunotherapy was done, transplant patients were excluded very simply because immunotherapy, as we know, activates the body's immune mechanism. So there is a big risk of graft rejection as such. There are no clear guidelines with regard to the use of immunotherapy in transplant patients. But what is the general consensus is it's a matter of choosing between life and graft. If it is a life-threatening malignancy, you sort of have to sit and counsel with the patients, involve the nephrology team, and have an understanding that yes, using immunotherapy will cause probably a rejection of the graft because the body's immune system is being activated. But if the malignancy is more life-threatening, then you'll have to weigh the benefits and risks and take a call.
Exactly. I totally understand. I mean, I agree with Dr. Nitin. So you will have to weigh risks and benefits of how much the graft functions is currently, how bad the malignancy is. If the malignancy is bad and it requires to be treated, maybe we'll have to give up on the graft rather than give up on the patient.
Okay. Dr. Reshmi, the next question that we have is actually for you. So
okay,
we've got to understand that the immunosuppressant drugs for a long-term use is one of the causes for cancer. So one of our patients have asked is, do we have immunosuppressant drugs that you would suggest that is anti-cancer, which means these immunosuppressants may not lead to cancer?
Okay. So immunosuppression generally means that your immunity is being suppressed. So that itself is a risk factor. But yes, there are certain drugs which have been used and tested in the trials, like everolimus. So they have tested these drugs in trials and found that the risk for malignancy post-transplant when these drugs were used was much lesser. I think Dr. Nitin will be able to share some ideas on that. But definitely the graft function is one more thing which we have to look at. Everolimus that way is definitely inferior to the current drug tacrolimus, which is being used when compared to, when you're considering the graft functions over the long term. So it's a trade-off. You will have to compromise over the graft functions or give these drugs. Definitely a strategy can be worked out where initially the patient can be on other drugs and later switched over to everolimus.
So just adding to what Dr. Rashmi said, I think for the common man to understand, the treatment of anti-cancer itself with chemotherapy, now chemotherapy themselves lower the body's immunity as such. So the whole immune system in the body is very complex. It's not 2 + 2 = 4 as such. When we talk of sort of immunosuppression and everolimus, which Dr. Rashmi mentioned, we in fact use it as an anti-cancer drug. Sometimes in second-line renal cancer, we sometimes use it in breast cancer as such. So then the public can ask us, why are you using an immunosuppressant to treat cancer as such? But medicine is always what we say more of an art rather than just being a science as such. And the whole immune system, as we saw during COVID itself, is a very, very complex mechanism as such. The one thing that I would like to say is that when you're talking of immunosuppression, and suppose someone has been diagnosed with a malignancy post being on immunosuppression, we again speak with our nephrology team and colleagues and take their opinion and guidance. Should you start reducing the immunosuppression when you're using chemotherapy? Again, it depends on the type of cancer. If it's a cancer which is associated with a virus or is a known oncogenic factor, we would say that yes, use a strategy where you sort of reduce the immunosuppression being used. And again, like Dr. Rashmi said, it's about using a strategy to balance the graft function with treating the malignancy as such. Now, again, just to answer the original question, are there immunosuppressant drugs which do not cause cancer? I don't think the answer is a straightforward yes or no. It's all about choosing the right drug with a favorable safety profile and trying to monitor for the development of cancer.
Exactly. We'll have to customize it to the situation and what the patient is facing. Exactly.
Thank you. Dr. Nitin, we heard you talk about the regular tests that should be done to diagnose certain type of cancers. But Dr. Rashmi, can you give us your views on this question, and then we go on to Dr. Nitin if he has anything to add to it.
Okay.
For a person on dialysis or for a person on CKD, are there regular routine tests that you would suggest for your patients in order to diagnose cancer?
Not really. We don't go looking for it. But yes, if patient has had certain symptoms or is having a family history of cancer, or definitely a post-transplant patient showing certain symptomatology, we do evaluate on that basis. But like what I mentioned in my talk, in end-stage kidney disease, cancer screening is definitely not a cost-effective tool, because you're not particularly screening means you're looking for cancer totally in the body. Unless you're looking for a particular kind organ cancer, then it's not worth the screening. Post-transplant, yes, there are definite protocols. We would want to screen regularly.
Can you talk about that post-transplant? Since you said there are different protocols, we'd like to screen. How regularly would you recommend this for post-transplant patients, and what are the screenings? Dr. Rashmi?
I'm back online.
Yeah. Do you want me to repeat that question?
No. The post-transplant screening protocol is recommendations would be the breast screening that particularly more than 40-year-old women, either breast self-examination or annual or biannual mammography, especially for women older than 50 years. Between 40 to 49, they could still undergo screening, but there's no evidence against screening at this particular age group. But these are protocols which need to be followed regularly in patients who are seeing the doctors when compliance is a matter. So post-compliance is definitely the first thing which matters. Colorectal cancer, like what Dr. Nitin mentioned, 5-yearly flexible sigmoidoscopy. Cervical cancers, regular cervical screening, the pap smears. Prostates, again, annual screening, the digital rectal examination and the PSA screening in all the male transplant recipients.
Yeah.
Skin malignancies, the scalp skin examination, that is the most important thing. If they note any lesions on the skin, they need to get back to the doctors immediately. Otherwise, once in every 6 to 12 months. Kidney malignancy, there's no firm recommendation, but if there are any symptoms related to the kidney, like passing blood in the urine, weight loss, or pain in the abdomen, which will be definitely later, or any graft dysfunction which has happened, we do screen them for it.
Okay. Dr. Nitin, you want to add something, or you're good?
No, it's the same thing. I mean, just from the colon cancer point of view, we would say either a sigmoidoscopy once every 5 years or a colonoscopy which we would say is sort of a better thing, which is done once in 10 years as such. So again, for patients on dialysis as such, we don't necessarily have any special screening protocols. Most of it, which is applicable to the general population, is applicable to them. I would only stress upon the point that it's very important to sort of not neglect any family history of breast cancer. We are moving into an era of molecular oncology. We need to look at, are hereditary cancers susceptible genes present in patients with family history of cancer? And if so, then the screening protocols in them are slightly more intense and start earlier as such.
Doc, when you say something like this out of curiosity, suppose a patient's father was a smoker and had lung cancer due to the act of smoking for maybe 40, 50 years. Will the children also have to look out if the children are non-smokers?
No, so you have very well-defined syndromes of hereditary cancer. So we typically talk about hereditary breast and ovarian cancer syndromes. We talk of hereditary colorectal and uterine cancers, which fall under Lynch syndrome. There's a certain type of kidney cancer, which is called as papillary cancer, which can be hereditary. So it's not just straightforward a family history, because again, like I said, it's only 1/3 of cancers which are hereditary as such. The rest are due to environmental and other factors. So no, always speak to the oncologist, understand what come under hereditary cancer, and is there a suspicion for it. There are well-established guidelines.
Thank you. Dr. Rashmi, you mentioned in one of your slides that there are tests that are done prior to a transplant to know if you have cancer on the cards.
Okay.
Not most of us. Are these tests done as a compulsion? Like there's every transplant patient definitely does the test? Because in my limited understanding, we've never heard of our community speak of any such test. So what is this test exactly?
No, there's no compulsion that you have to undergo these tests. If you're not symptomatic, definitely not a requirement.
Okay.
But cancer screening as a protocol, it depends on the institution's protocols, definitely not a guideline as such.
Okay.
That is the institutional protocol.
And what is the test that is done before the transplant in particular?
Here
If it's
in
a male and
Manipal
if it's a
Hospital,
female.
we practice in Manipal Hospital, Vartur branch. There we do something called as an oncology CT, which is run through the complete body CT, which will detect any kind of early malignancies as well.
Okay. Dr. Nitin, are you around?
Yeah, I'm here.
Yeah. We have a patient who says, I was diagnosed with ovarian cancer stage 1. I have had my surgery and 3 rounds of chemo. I'm worried about my cancer coming back. Would you like to comment on that?
Yeah, so it's very good that she has been, again, there are different types of ovarian cancer. There can be what is known as, the most common is epithelial ovarian cancer. Then there is germ cell tumors of the ovary. So a little difficult to comment upon the exact recurrence rates without knowing what is the pathology type as such. But again, sort of any cancer which is diagnosed in stage 1 has a very good prognosis. The chances of recurrence are less than when it is diagnosed in stage 3. And the very fact that she is receiving what is known as adjuvant chemotherapy, that is, if she has undergone surgery and then received chemotherapy, further lowers the risk of cancer coming back. So I wouldn't worry too much. I would say if she has been diagnosed, a good surgery has been done, and she's following the protocol of adjuvant chemotherapy, she should just be on a surveillance protocol as advised by her oncologist, and hope for the best. So again, so in stage 1, we say the prognosis is very, very good.
Okay. Thank you, Doc, for that. Dr. Reshmi, I'd like you to go for this question if it's possible. What kind of diet and supplements would you recommend for a kidney transplanted recipient who's diagnosed with cancer?
Sorry, please come again.
What kind of diet and supplements would you recommend for a kidney transplanted recipient who's diagnosed with cancer?
Okay. So definitely depends on the kidney functions at that point of time. No supplement, but yeah, nutritious diet, but depending on the amount of kidney functions which are left right now, whether the patient is having normal kidney function
Okay.
or has already developed graft dysfunction. Depending on that, the protein intake, everything can be fixed. But post cancer diagnosis, I don't think the nutrition changes much or the diet changes much from the kidney point of view. Definitely,
Okay.
Dr. can add on more.
Yeah, so just adding to it, I think it's sort of an experience with patients in India that the first question that they ask after diagnosis of anything, be it dengue to malaria to cancer, is what should we eat? And nutrition is an important aspect. Now, we say mostly when patients are on chemotherapy, try to avoid raw food, try to avoid uncooked food, because more from a hygiene point of view, and again, from an infection point of view as such. But barring that, we try to encourage as normal a diet as possible. Again, we sort of say try to avoid consumption of red meat or processed meat, because there is some evidence to show that they are carcinogenic as such. But barring that, not really. We say again, post-surgery, especially when there is post-ovarian surgeries or abdominal surgeries, we leave the nutritional aspect to the surgical oncology teams. Nowadays, they are coming up with enhanced recovery after surgery protocols where there is early mobilization, early nutrition, oral feeding as such. So post-surgical management of nutrition is different. But if someone is on chemotherapy or immunotherapy, we say eat clean, hygienic, cooked food.
Okay.
I agree.
Not one of the questions that have actually come for the community, but one of the questions that I just thought we'll ask both the doctors. It's a very recent past discussion that we've had in the community about cancer associated with CKD or being an offshoot or either being a reason for CKD. We all understand with our limited understanding the chemotherapy and how it can affect with an acute failure, that part of it yet. Yes, but for people who are already on CKD and then getting cancer is a very, very new topic. Is this something new or is it something that's just catching our awareness right now? Dr. Nitin?
No, I don't think it's new. So if you actually do a Google search of cancer and CKD, you have scientific papers coming right from 1999 onwards. Now, that is the point that I would like to make at the beginning, made at the beginning itself. You have the cancer in the general population increasing, which is why even in the CKD population, you are seeing it increase. Now, when you, of course, look at the risk factors, yes, due to the sort of inflammatory pathways, patients on CKD being having a sort of a pro-inflammatory state in the body, the risk factor for them developing cancer is higher than the general population as such. And again, the understanding of this is something which is continuing to evolve in terms of the scientific pathways and all that. But in terms of, again, like I said, if you have, let's say out of 10 people, if you have the disease developing in one person, it's still 10%, right? But if you're out of 100, if you have in 10 developing, it catches your attention. So essentially, the incidence is increasing in the general public as well. And that is why you are seeing a reflection of it even in certain communities like the CKD.
Okay. Yeah, I agree with Dr. Nitin, but what I would like to add is like now there are more screening techniques and a plethora of molecules which have come in oncology, this thing, which are catching more attention because they do have side effects concerning the kidney. And CKD, definitely it has been existent, recent increase in the numbers of CKD, so probably we are catching more number of with CKD. Yes.
We had an interesting question that's coming up for mental health. And this is in particular to Dr. Nitin's perspective first. How to cope up with the impact of cancer on one's mental health. Generally, cancer itself is quite a demanding disease from all our understanding, especially if diagnosed much later. So what is the first thing that you would tell your patients, doc? Do you get into that or how?
Yeah, so I think when we talk of mental health, it's, I mean, recently there are studies being done on oncologists' mental health also because, and somewhere down the line, as nephrologists and oncologists, we do deal with patients who are faced with overwhelming challenges, and that too for a long term as such. So it is an enormous impact, not just on the patient, but also on the patient's family members. something which we refer to as caregivers burnout also that we often see. And again, one more interesting aspect in India is often there's a request from the family that do not break the news to the patient, because most of them are under the assumption that a patient will not be able to, handle the diagnosis of cancer itself. So these are challenges which we face on a day-to-day basis. We believe in being, at least in Manipal hospitals, we believe in being open with our patient to a certain extent, giving them positivity, telling them that it is a disease which can be treated and cured. Even if it is stage 4, we always tell them that yes, it can be treated. It may not be cured, but we'll be able to control it and prolong survival if it responds. We also try to give examples of diabetes and hypertension. Now, these are diseases that you cannot cure, but you essentially control them. We are now moving into an era where even a stage 4 cancer in certain diseases, we are able to control and keep the disease suppressed as such. So that is essentially the way we start off. We do give examples of other success stories like the ones that I shared, where we saw remarkable responses. Very, very important to be forthright and very frank about the side effects of treatment that we give them, because you need to prepare them for that. And I always tell them that sometimes you cannot avoid side effects, but you can prevent the side effects from becoming a complication by reporting it early so that we can take steps. And there's a huge role of the family to play. And most of the time, it's the counseling to the family that is important, because I noticed recently, it was told in another forum as well by a patient's attendant itself, that after the diagnosis of cancer, please do not tell to any relatives, because it's the relatives who try to cast a shadow of gloom, death sentence and everything. So most of the times we ask the patient's family to stay positive, do not try to Google or try to indulge in too much of false news and fake news. Clarify all the doubts that they have with us directly. And it's all about filling hope. And we always say, don't look at long term. It's all about staying in the present, taking one step at a time, chemo, surgery, radiation, and moving forward.
I agree with Dr. Nathan. Like, it's the same with chronic kidney disease. With or without cancer, chronic kidney disease is definitely a long journey with the patient and the doctor. Staying positive is one thing, but at the same time, like what Dr. Nathan said, educating the patient, it is the most important thing. At the same time, not creating panic and pressing a panic button to them. Definitely staying positive is the thing.
And also we have a relatively new and upcoming field of psycho-oncology. And that is sometimes we use their help, because sometimes as practicing clinicians, it's very difficult to devote the amount of time which is needed. So we do take in their help for distress screening, for trying to take their help to suggest relaxation techniques. And of course, again, the role of physical activity, yoga, and the other things which are needed to keep a positive frame of mind is underemphasized. So we do try to talk about these things as well to our patients.
The same with nephrology as well. We do have kidney disease CKD counselors who do this for us. So definitely a requirement.
So that brings us to the end of our 1 hour of understanding the connections between both the diseases and of course, do's and don'ts. And I think such a heavy topic broken down so simply by both Dr. Reshmi and Dr. Nitin. It is indeed our pleasure to share this 1 hour with you. And we are very grateful on behalf of the Kidney Warrior Foundation. We'd like to say a very big thank you to both our doctors for joining us today in spite of their busy schedule. It is greatly appreciated by the community and us. And that brings us to the end of our session.
And I would like to thank you, Ms. Marian, and Ms. Vasundhara for this opportunity, and definitely Dr. Sundar for this opportunity. And we would be open to any further questions on this. You can reach out to us at any point of time.
Sure.
Thank you so much. It's a privilege to be on this.